Buprenorphine is one of 3 medications approved for use to treat opiate use disorder. It's available in a film or tablet and 2 different long-acting extended-release injectables. Sublocade was first approved by the FDA in November 2017, and more recently, in May of last year in 2023, a second buprenorphine injectable, Brixadi, received approval. Then in January 2024, Brixadi was added to the Washington State Medicaid formulary, so clinicians have just begun to offer Brixadi. The Clinical Trials Network Pacific Northwest Node participated in 2 national clinical trial network studies that used Brixadi. We invited the clinicians involved in these studies to share their real-world experiences and lessons learned as part of the June 13, 2024 University of Washington Psychiatry and Addiction Case Conference. Thank you all to this wonderful panel. We have quite a broad range of experience already in such a new medication. So I'm so honored and excited to hear all that you have to offer. Before we jump into questions, we want to level set a little bit with some background and information about Brixadi. So Dr. Whiteside, I think you're going to give us some presentation for a few minutes here to bring the group up to speed.
I wanted to touch base on sort of just Brixadi, the basics. So it received full FDA approval May 23rd, 2023. Prior to that, it had been used for the MOM study and for ED innovation in study settings, and it has been used pretty extensively in other countries, Australia in particular. The indication for Brixadi is very familiar, moderate to severe OUD, and it comes in these 2 formulations. So the weekly injectable, which is in this purple column, and then the monthly injectable, which sits in that sort of teal column. I do want to note that in this first gray column is sort of the equivalent daily sublingual buprenorphine dose. So if you're thinking about somebody who you would, in a sublingual setting, maybe be thinking about a total daily dose of 16 milligrams. The equivalents in weekly Brixadi would be this third row, 24 milligrams, or 96 for the monthly. This is a bit of an overview, compare and contrast of the 2 long-acting products. Sublocade, the monthly injectable, the first column, and Brixadi, the injectable we're talking about today, in the right. Both are approved in our country. They've been used in Australia. A couple things to note, indications, that second row here, the Sublocade, the FDA indications are that, for adults with moderate to severe OUD, tolerating sublingual bupe at 8 to 24 milligrams per day for at least 7 days. Brixadi doesn't have that run-in as part of the FDA guidelines and indication. The dose and mean buprenorphine concentration, I just give here to show that there's various doses of Sublocade, just as there are various doses of Brixadi. I didn't list them all here, but you can know that the steady state is sort of greater than 1, and I'll talk a little bit about that in a figure coming up. Injection reported to be painful, ? Is the next row on this. For Sublocade, I think we're all familiar with patients who sort of report that to be painful, leave a small bump under the skin at the injection site. For Brixadi, that seems to be qualitatively less so. And then for the administration site for Sublocade, it's really the abdomen area. For Brixadi, and I have another figure, there's a couple more different options. Is refrigeration required? For Sublocade, yes. For Brixadi, no. I think that can be important depending on your site for things like pharmacy storage. And Dr. Folkley is involved in some EMS conversations around, could we be doing this in the field, Brixadi in the field and stuff like that. Not happening yet, but that would be important. So if you're transporting this, using it in community sites, how to make sure it's stored properly. This is the graph that I think helped me figure out how to kind of start this on patients. So if we have plasma concentration by time, and this graph was published as part of a review on the ED innovation study that was published in a journal called Academic Emergency Medicine. But plasma concentration by time, and you can see if you follow this gray line with the squares, that's sublingual bupe. We're all familiar with kind of the rapid onset of sublingual bupe, given the high affinity for the opioid receptor, so that really by about 30 minutes, you're getting peak onset of action. And then that falls off, and that's why we some patients prefer to dose multiple times in a day with sublingual buprenorphine product. With Brixadi, it's depicted here in the black line with circles, and you can sort of see that at around 4 hours we get this concentration that suppresses cravings and mitigates withdrawal symptoms. And by about 20 to 24 hours, you have peak plasma concentration. And so if you're thinking about starting somebody, you really have to sort of think about how they, those first 24 hours and how to manage withdrawal symptoms. And this may be enough. It may be that you want to provide that patient with some sublingual bupe to sort of get through the hump based on how much withdrawal they're having. This is what we provided all of our nurses that gave the Brixadi injection. The figure on the left is placement of injection. So those are all the places that one could safely get the injection based on the approval from the FDA. And then the injection instructions are pretty straightforward, and especially for a nurse that has done injections. For our nurses, often noted that this felt very similar to a Lovenox injection. It comes in a pre-filled syringe. You just twist the plunger in, remove the needle shield, pinch the skin. Instruction number 3 is to put the needle in parallel to the skin. And then number 4, as a slow deep press of the plunger, kind of count for 2, and then pull the whole apparatus out. It's very straightforward and feels very similar to subcutaneous injections that nurses have given before. We instructed not to rub the injection site, and to make sure that you instruction number 6, remove the thumb from the plunger to retract the needle. So it's all sort of self-contained, and then that whole thing can be disposed of. The last practical elements to discuss here is that this medication is covered by the Washington Healthcare Authority. There is no pre-authorization needed. It does not need to be dispensed from a specialty pharmacy, but does need to be given by a healthcare worker. So it's not something that a patient can self-administer. It needs to be administered when a patient is experiencing mild to moderate withdrawal. And for the purposes of the study that I provided this to patients as a part of, we used COWS, the Clinical Opioid Withdrawal Scale of greater than 4 or greater. That's a bit of a typo. And then, as I kind of alluded to, you can provide the patient with some sublingual buprenorphine during initiation to provide more immediate and complete relief of symptoms while you're waiting for that steady state to occur, which usually occurs around 20 to 24 hours.
Fantastic, Dr. Whiteside. Thank you so much. I'm going to go ahead and kick us off to ask the 4 of you, and I'll let you guys spontaneously each answer, but I would like all 4 of you to weigh in on this first question, which is describing how long you've been using injectable buprenorphine and how you're able to access that medication. And a little bit following up on what Dr. Whiteside just talked about, how well are you seeing Brixadi getting covered by insurance, or the best ways to get Brixadi covered?
I have been offering Sublocade as a treatment option to patients who are choosing it since it became available with us. And Brixadi we have been using as part of the MOMS trial. And regarding coverage for Washington State Medicaid, it is on formulary for all 5 plans, including preferred status. So as far as I know, there are no restrictions. It is also on the formulary for the United Healthcare and commercial plans. Cross Blue Shield plans, it is on the national formularies, and the regional plans such as Premera and Regions. Brixadi so far is not covered, and for instance, Swedish and Providence is currently working to put it on the formulary by the end of this year. I also know that it is on the formulary for CVS, Express Scripts, Cigna, Optum, and Medicare also has been extending coverage.
Importantly for us, I can speak to kind of like the Harborview downtown programs as we've been thinking through our office-based opioid treatment program and thinking through the process and pathway by which we've talked about insurance, is that previously we had even though it was on the Sublocade, even though that was on formulary for the healthcare authority for Medicaid, we were still going through the process of just ensuring that patients didn't need a PA, which was really time intensive for a lot of the administrative staff for our OBOT program. And then we as a clinic decided that that was just unnecessary. We had gotten many times reassurance with the healthcare authority that it was on formulary. You didn't need to go through a specialty pharmacy. And that's actually like opened up a lot more time for those administrative staffs to kind of address other issues.
So as an emergency medicine doc, Sublocade is not part of our current practice. So I'm really coming at this from the perspective of using Brixadi exclusively as my experience with long-acting injectables. We have the benefit of a longer sort of face-to-face with the patient and can do, we feel very comfortable doing observed starts and initiations with sublingual bupe and all the things all the ways that could go wrong, although it doesn't often. And so there's no reason to think that we couldn't do this in the emergency department with long-acting injectables. It is on the formulary within UW Medicine and have worked with outpatient partners to make sure that's happening.
I've been using injectable buprenorphine Sublocade for the past several years. Basically have been just getting it from the facility pharmacy in the first floor of our clinic. We recently, I was able to ask the pharmacist who runs that to see if we get Brixadi in stock, and that was not a problem at all. They were able to get it very, very quickly. They had to jump through a bunch of hoops just to kind of get everything set around Sublocade, and it seemed a pretty easy transition to start to stock Brixadi. From a Medicaid standpoint, no issues around restrictions. Prior auths haven't been an issue ever since I've been using Sublocade. I have had some where the commercial insurance was not covered, but the patient was very interested in getting it, and it ended up being quite a costly medication for that person after they got it, and the injection, even they were kind of surprised at, although they knew it was a pretty expensive injection, so it was a few $1,000 bill that they got. But and so in the end, it is kind of worthwhile knowing what's covered and what isn't, because the cost, despite you going over it, will be a shock to them once they get that bill. In that particular case, I was mentioning the person ended up just switching to sublingual buprenorphine and is doing well. So the injectable was helpful to transition from a full agonist to buprenorphine, but after that, they switched easily to sublingual.
Another question our community advisory board has for all four of you is, who are you offering injectable bupe to?
Everyone. But we also are providers on a telebuprenorphine hotline. So we get calls from folks, and particularly in King County, calling, asking about buprenorphine. I think in all those conversations, I often like to float the idea that putting it out there that there are long-acting injectable medications, especially for patients who in some of the settings that I work in, and most of the settings I work in, may have a lot of social insecurity or experiencing homelessness and some other kind of complications in their lives that make taking a medication every day complicated. So I think bringing that up, not just as a medication option after starting sublingual buprenorphine, but potentially as the option to get started. I think what gets me excited in the kind of scaffolding I'm trying to think about is the patients who long-acting injectables might be a good way for them to get started on the medication, and then for those who need to be maintained on that medication, and even for patients thinking about maybe slowly titrating off the medication. I think long-acting injectables have an interesting role in kind of all of those settings, but I'm also really excited and inspired, I think, by seeing patients do so well on long-acting injectables, that I just think increasing access and thinking about how we can especially help patients get on buprenorphine through long-acting injectables is something I'm really, really excited about.
I wanted to add that as a clinician, I try to embrace a patient-centered whole person approach where I ask for permission to offer education and information and try to promote wellness, to celebrate people having voices and choices in the treatment options that they choose. And I find that this is very therapeutic, also very much inspiring people to appreciate their own autonomy to make shared decisions that feel safe and comfortable. And as Kaylin pointed out, people like flexibility and knowing that an extended release buprenorphine is a very practical option for them that is available means a lot to them.
Vanya, what you said about sort of a patient-centered approach and Kaylin, you sort of mentioned this menu of options, I think really speaks to me. So on the total flip side of that, as sort of the person that was providing Brixadi in the setting of a randomized clinical trial, we were really asking patients to not participate in the choice, but to sign up to be either assigned in the sublingual arm or assigned the injectable arm. And it was striking to me how we had patients that agreed to that we still had people voice preference like, man, I want to sign up for your study, but I really hope I get one of those. And some folks really wanted the injection. They really wanted to be free of the barriers of all the things that can happen between pharmacy, and other folks really wanted sort of more control over the day-to-days and really wanted the sublingual product. And so I think this idea that that having, you know, these options for patients and helping patients understand where maybe initiation with the injectable is a good idea, and then you can move to a sublingual version or vice versa, and how to tailor that for patients really speaks to me.
You know, we've definitely had those experiences where people really do very well. Those who had problems just kind of adhering to sublingual buprenorphine doses, especially if we're giving them, you know, a fairly high dose. So if someone has, you know, a 36 milligram dose and they need to take 3 films of 12 milligrams, you know, that's going to be hard for someone. That might be hard for someone to take, or if they try splitting their dose up. I've had people where they don't take their second dose later in the day. So it's really nice to kind of take that adherence piece just off the table, and the injectables provide a nice answer to that. You know, at the beginning, I'll offer it to people that I currently have on buprenorphine sublingual, just so they know about the options that are available, and maybe someone who's been pretty stable would like to kind of use an injectable versus the film for a number of different reasons. You know, in part due to you know, just not having to take something every day.
Are you using injectable bupe in pregnancy, adolescents, or people with pain issues? And what do you know about the safety of Brixadi in pregnancy versus Sublocade? And why might that be different?
Pregnant people, adolescent, or people with pain, we know that buprenorphine has unique qualities as an analgesic, and there is extensive data for acute and chronic pain management. I also try to really discuss with the patient that the weekly, for instance, extended buprenorphine formulation has several dose options, and dose adjustment can be made using this particular formulation. I explain the pharmacology in terms that the patient can understand. So the lack of daily peak and trough levels, for instance, that people experience with sublingual buprenorphine may create a different subjective experience with people who have previously been taken the sublingual buprenorphine. And if we talk about pregnant and postpartum people, Brixadi is a really good medication. The difference, the major contributor to differences in buprenorphine is related to the activity of CYP3A, which we know that increases during pregnancy. The weekly injection works really well for pregnant people. It is also very safe in breastfeeding. And the second portion is Brixadi and Sublocade both. You mentioned safe in pregnancy. This is related to the N-methyl-2 pyridone, NNP particle, which is extensive as an organic solvent with many applications in electronics or, you know, just other industries. And Sublocade has it, so we do know that it passes in the placenta. It crosses the placenta, and there are some rat studies that show toxicity. We do have a couple of case studies that show that using Sublocade for people who choose and who are counseled on it have had really good outcomes.
how are you guys choosing the injectable bupe formulation to use, Brixadi versus Sublocade? And maybe comment on the high levels of synthetic opiate use that might be a consideration, or other considerations that you have.
All of us can appreciate that we live in a fentanyl era where our patients are extremely scared of precipitous withdrawal and how they can transition safely to a medication. So as being able to listen to get a better history of what has worked before, how we can make this a comfortable process, to me, is the biggest drive on what kind of formulation I can offer and include the patient's input and choices that they would like to potentially have in their treatment. Brixadi has a lot of benefits. The needle is a 23 gauge needle, which is much smaller, less painful. With Sublocade, we can numb the area with lidocaine, and this has been working really well. Also with Brixadi, you can choose different sites. You can choose the upper arm, the abdomen, the buttock, the thigh. With the upper arm, usually has been used only after steady state has been achieved, which is in our CTN trial, it was 4 weekly doses that we required because of the arm has 10% lower plasma levels from other sites. But also the solution is much smaller, and usually it does not create a bump under the skin. So it is much more tolerated. And I find that patients meeting people where they are is how we choose what formulation potentially might work for them. I also have had a patient who was on Sublocade, and he requested to transition back to sublingual formulation because he thought that this is my recovery, and my recovery is taking the medication every day, to be reminded to go to meetings. And as a provider, we do try again to appreciate people's input and meet their needs.
I feel like the things that have come in when talking about it as like the Sublocade versus Brixadi. One is what has worked for them before or hasn't worked for them before. And two, like if they've gotten Sublocade before, what was that experience like? And thirdly, like what is kind of like their interest like long-term, and how do they want, what is their relationship that they want with these medications? My experience with Sublocade doing kind of cold starts, meaning that like patient hasn't been on sublingual buprenorphine for 7 days prior, can have pretty significant withdrawal symptoms associated with their Sublocade injection. Often combated with sublingual buprenorphine. So some patients have had really difficult initiation or starts with Sublocade. It's been really hard to figure out which patients are going to have the really extreme reaction versus the maybe like they feel a little uncomfortable, but they can kind of get through this with sublingual buprenorphine. At least anecdotally for me, it doesn't seem like it's necessarily like proximity to use or like how much they use necessarily. It does seem like if patients wait longer and maybe get some buprenorphine in their system before getting the Sublocade, that it can be eased. For patients who are worried about that, have heard about these cold starts and have had difficulty getting on sublingual buprenorphine, maybe Brixadi is maybe a softer launch to get patients started. There is evidence of like less precipitated withdrawal with being started on Brixadi, at least in some of the studies. And I think that's something I also like to talk to, like something I'm thinking through with patients about, like how do we get patients started when sublingual buprenorphine starts have been rocky. Sublocade seems really scary to them, but maybe Brixadi is a potentially a good option. The other patient category that I'm thinking about are like patients who just want almost like that very slow start, like they just want like a kind of low dose buprenorphine, like 8 milligram weekly. Feel how that's like, and then like kind of redose the following week and just kind of feel like want that kind of slow roll into getting started on a medication. And I think Brixadi gives a little bit more options because they're both weekly and monthly dosing that you can kind of layer on.
The 4 points that I will bring up with people when we're talking about either Sublocade or Brixadi is, potentially around that ease of starting, as Kaylin had described very well. You look at that ED innovation study, very reassuring around not dealing with precipitated withdrawal. And you saw that nice kind of gradual increase in the dose of buprenorphine over 24 hours, which is much different than the graph of Sublocade, where you had that huge spike and drop, which might be contributing to some of the precipitated withdrawal that we're all seeing with Sublocade. The other point is around the pain around injection site. The liquid itself is much smaller, the needle is smaller, the bump should not be very noticeable, and that can be a very big point for people, especially if they're in a situation where they don't want people to know they are on an injectable buprenorphine. So I was talking with some adolescent providers in particular, where these kids are living at home, and so they may have parents that are not very supportive of MOUD. And so having an injectable that is not going to be seen, is a very appealing option for them. If you look at some of the dose steady state concentrations between Sublocade and Brixadi and what you can achieve with one or the other, at the highest dose of Sublocade of 300 milligrams over the course of 4+ months versus the highest dose of the monthly Brixadi over the course of 4+ months to get to that steady state, you do see a higher dose level with Sublocade. And I've had some people say, well, I've needed a very high dose of buprenorphine in the past, and I want to go for the kind of the max dose that we can get to. And that has been a reason that they've gone with Sublocade.
How are you getting people started on Brixadi? Some of you have started to discuss this, so we really want to know, how has the induction experience been? And do patients potentially starting Brixadi often require supplemental SL buprenorphine initially, like with Sublocade? So can you share your experience along those lines and any protracted withdrawal that you've seen?
The initiation of Brixadi, if people already are on a steady sublingual dose, we usually would do equivalent dose. And very quickly, we learn that patients require a higher dose of the injectable. People who are not on the sublingual buprenorphine, we would offer TM buprenorphine 4 milligrams when they were in withdrawal. And then this was kind of a test dose. And then we will give a Brixadi injection of 16 milligrams. There's also a recommendation to give 8 milligrams 3 days later, if that is needed. And one tip that we found out that was equally helpful was, instead of offering an extra injection, we would offer a supplemental sublingual buprenorphine, which has been working really well. And a lot of the patients who we had on the injectable did require supplemental, which was very much and well tolerated.
I'll say at Harborview, 80% of our patients that have opioid use disorder are co-using methamphetamine. And so the COWS score was really impossible to interpret, because a lot of folks that were co-using were either coming down from their methamphetamine intoxication while simultaneously having opioid withdrawal symptoms, and that is tricky. So in general, we tried to really make sure that patients had been not using fentanyl for somewhere around at least 12 hours, 10 to 12 hours. And the obvious ones were patients that came in an obvious opioid withdrawal. And some of them had precipitated their own withdrawal, maybe as an outpatient, trying to start sublingual bup on their own. Those patients clinically would get sublingual bup before we could even talk to them to get informed consent for the study, sometimes up to 16 milligrams. So if their COWS score was high in like the 20s to 30s, they would get enough bup to be able to have a conversation. Maybe their COWS is now in the 10s, and then they would get randomized in the study to Brixadi and have a nice transition there. Or they also got all the medications to treat their symptoms, Zofran for nausea, fluids, NSAIDs for kind of muscle aches, that sort of thing. And sometimes after the injection, we would give them more also. That was okay within the protocol of our study. We also had a group of patients that just had mild symptoms. Some patients that maybe were just coming out of the criminal justice system, were having cravings, but their COWS was 4, but a lot of sort of subjective complaints and a history of use that was distal. And those patients would do fine with just the injection, and they really didn't need much else. And then we had a group of folks that would have COWS of greater than 4, but maybe their use was with, around 12 hours, and they were also using meth, and there'd be, give them the injection, and some of them would need sublingual bup and some of them wouldn't, and some of them might need clonidine or Zofran or other things, and some of them wouldn't, and it was really personalized at that point. But I say all that to say, we did not provide patients with sublingual bup as a requirement to start the Brixadi. We did that if it was clinically indicated based on the patient's acute presentation having a severe withdrawal or not.
And just to clarify, Lauren, with the if there were patients who hadn't been on buprenorphine before, they could still get the Brixadi, right?
We asked about allergies, but we didn't sort of do like a test, and there were no problems there.
The kind of like handful of patients who and that my clinic has started on Brixadi, it's mostly been a lower dose, so kind of like the 8 milligram dose weekly, to just kind of like ease people into taking a long-acting injectable. And interestingly, just again, anecdotally in those handful of patients, the like kind of precipitated withdrawal that I think we've experienced in the Sublocade setting hasn't been the case, even though I think folks have come in using fentanyl really in close proximity to getting their Brixadi injection.
What have patients shared about their experience on Brixadi versus Sublocade? Have you guys had many patients that have been on one versus the other and offered you any feedback?
I have not had a patient who has been on Brixadi and Sublocade to be able to compare. The feedback that I have from patients who have been treated with Brixadi and Sublocade is that having options and the long-acting injectable buprenorphine really works well for them. I also have had a few people who have been able to wean off buprenorphine by using long-acting injectable. And again, being able to be a listener and to be present for the patient and meet their needs is something that really works well for them to feel supported in their recovery journey.
We want to know what your experience as a prescriber of Brixadi has been like.
It was really easy. So, and some of it was, my setting is the emergency department, but order the med, pharmacist brings it up, nurse gives it, and then it's done.
I can't speak to the experience of giving Brixadi, but I'll speak just to the broader experience of doing an injectable that lasts for 4+ weeks. I mean, that's a very reassuring feeling from a provider standpoint. Just because I've had plenty of patients who, again, the adherence piece on the films just has not been great, and in some cases have even had an overdose, accidental overdose at times. And so I mean, there's, selfishly, there is a certain sense of peace once I know the injectant is in, and it will have, it's going to have some effects here over the course of several weeks and really help people start to make some significant changes where they haven't been before. So it's been a positive experience, seeing some of the changes people can make. And so it's really made me a provider that's a kind of an advocate for this to be an option for people.
And I will add that the medication doesn't need to be refrigerated, so it's very easy and then doesn't give a bump to the patient, and it's well tolerated with less pain, which makes it very easy. And my experience has been very positive for Brixadi.
Also, it's been really easy for the nursing staff. Like with ED Innovation, it was like kind of just-in-time training for the nurse prior to administration. So it was really easy. What's been really nice about Brixadi is like, it feels like anyone can do it.
When has injectable Brixadi or Sublocade on the flip side not worked?
I have had a person who had requested to go back to sublingual. If people have protracted withdrawal symptoms and they need up titration, I usually offer that. And I try to work with the patient to feel satisfied and content with the treatment choice that they have made.
So similarly, I've also had a patient decide to go back to their sublingual buprenorphine, and that was because they liked to have the control over how they dose their buprenorphine. And for this particular person, they just could not relinquish that, and so they would experience, just kind of that worry that they were always going to be in withdrawal. They also used kind of their dosing of buprenorphine as a bit of some coping here and there when stressors would come up, and because that was just not necessarily available, although I was giving them films, they didn't feel it like they normally did with the films at their regular dose. Anyway, that person switched. I've had people where it hasn't worked because of financial reasons, where it was too expensive, and that was in a commercial patient scenario. And then I have had a patient where it didn't work. And I think this was a little bit on my end where I didn't follow them closely enough. So, with any injectable, there can be a tendency to be like, oh, okay, it's going to last for at least a month, maybe longer. I'll see you in a month. Well, in reality, there's a lot that can happen in between that time. And so, now I keep much closer track of things along the way to make sure that, what they're experiencing is working for them. They need some supplemental buprenorphine, or do they want to switch instead of just kind of losing track of things?